speaker, Dr. Mari Mitrani. Dr. Mitrani is the Chief Science Officer and co-founder of Organicell Regenerative Medicine Inc. and co-founded the American Cellular and Anti-Aging Center in Ecuador. We are incredibly grateful for this shadowing opportunity and hope to learn a lot today. As a reminder to our Club Med virtual members, if you'd like to have your camera on, we highly encourage it as long as you stay on mute while Dr. Mitrani is talking. There will be a survey given at the end of the session for Wayne State University students to obtain shadow and attendance hours. And to reiterate, only Wayne State University students present today can receive those hours. We're also recording this session, so anyone watching from YouTube, hello, and thank you for watching. And all right, I guess I'll turn it over to Dr. Mitrani so you can start whenever you're ready. Thank you.
Thank you so much, Jessica, and thank you for everybody for joining me today. I know you have 1,000 things to do, but you decided to join today. So I'm gonna start sharing my screen. Jessica, just confirm once you see it, so I know that we're going. Okay, perfect. Let me see how I move this thing up. So today we're gonna talk about regenerative medicine and why regenerative medicine, because that's the field that I am in. It's a field that did not exist. It is really brand new. And I am the Chief Science Officer of this public company that is working on biopharmaceuticals. So a little bit about me. My name is Maria Inés Mitrani, but it's a little complicated, so I do go for Mari. I am from Ecuador. I was born and raised in Ecuador, and I went to med school there. It is a little different than the US and other parts of the world. We don't have college and then university. That there is just from high school, you go straight to university and do 8 years of med school. But the basics is the same, because you do those first years of the basic biology, chemistry, and then you go into the deeper end of med school. So I went to Universidad San Francisco. I recently just got my my plant-based nutrition certification from Cornell. Unbelievable, as I've always been passionate about nutrition. I got my PhD in Ecuador as well, on neural therapy. So working with the parasympathetic and the sympathetic nervous system. And I thought I was going to stay as a clinician. My dad is also a doctor. With my mom, they run a clinic, and I try to specialize with as many things as I could to stay and work with them and keep pushing the hard work that they have done for over 45 years in preventative medicine. I also got my Doctor of Acupuncture degree, and I was granted a missionary medical doctor because we've helped, as you might know, Ecuador is a third world country. So I've participated in several crusades of physicians, of US physicians that always came to the Ecuador to help treat patients. So currently, in the position that I hold, there's many certifications that I need to have. Some of them, just to give you an example, I am certified under human subject research and GCP for clinical trials for investigational drugs. So, and a little bit about the past and the present. As I mentioned, I did co-found this company called American Cellular and Anti-Aging Center in Ecuador over 13 years ago, which was one of the first autologous stem cell centers in South America. And throughout the years, we kept progressing and understanding the world of stem cells. And then we're able to open other clinics and centers with physicians from those countries in Guatemala, Trinidad and Tobago, and Jamaica. So today I am the Chief Science Officer and co-founder of Organicell Regenerative Medicine. And just to give you an example of the amazing individuals that we have seen throughout the years, every single patient for us is still dear to our heart. In the old days, we used to have a lot of Hollywood people that would come down to Ecuador to get treated. And recently, one of our physicians treated this double time NBA champion Lamar Odom, but so many others that have passed through all of these years. Just to give you an example of what my field looked like, and well, we started with as a private company and transitioned it to be a publicly traded company, and we are very specific, committed to the research and development of manufactured new biologic medicine with a focus on the current and potential regenerative therapeutics. We are located in the CIC in Miami. This is a University of Miami. It's called the Life Science and Technology Park. This is our headquarters. Usually I'm there. Today I am in Colorado. We are venturing and opening a second laboratory here. So that's why I am going back and forth. And we are registered with FDA as a human cell and tissue establishment. So what is regenerative medicine and why I am so passionate about this? Regenerative medicine is the branch of medicine that specializes in replacing, engineering, or regenerating human cells, tissues, or organs. And it optimizes the human's body natural ability of healing itself. And this is probably why I'm so passionate about this last point, because we all have that potential. Every single body has the potential of regenerating itself. The body does have a biological clock, so we will be aging regardless, right? But there are certain things that if we can bring the correct message to those cells or tissues or organs, those cells, tissues, or organs can actually revert or go back to their beginning in terms of knowing how to act and why to act, and reverting or regenerating how they are acting, right? And I'm going to be a little bit more specific while we go through. But throughout the years, and I want to tell you a little bit about my how I went through all of this. As I mentioned, I thought I was going to stay in the clinic and see patients every day. Never did I think that I was going to transition into this different world of opportunities. But that's how life is, and life goes different ways that we do not anticipate. And we were presented this opportunity of working and researching and studying with stem cells. Back then, stem cells were not taught in any university. It was very, very new. And we were really fortunate to be able to use protocols of physicians that were working with autologous stem cells. And I'm going to talk a little bit more about those. So throughout the years, we have understood what stem cells are, where they come from, what do we need to do to them for them to work properly, what are the sources, the better sources. And we have transitioned now to a point where we are producing a new drug that is biological drug, and that it does not contain stem cells anymore. So just understand how throughout this more than a decade, the field of regenerative medicine, the field of stem cells have changed so much. It changes so fast that we have had to stay always on the top, understanding what are the changes that the whole scientific community and medical community are doing for us to keep progressing and improving to the point now that we are producing a drug. So to understand regenerative medicine, I love to give this explanation and separate it into two, because this is the best way to understand the types of therapies that exist out there with stem cells or with regenerative medicine. So you have two scenarios. Either you are taking it from your own body, that's called autologous. Autologous is coming from the patient's own body and then getting implanted into the same patient. So the donor and the recipient is the same person. And allogeneic, it means that it's a donor that is donating those cells, those tissues, those organs, and then implanted into another human. So the donor and the recipient are different. To specify a little bit more, what is autologous and what is allogeneic, I'm going to give you some broad explanation of what these are. You can use these cells or tissues that are coming from the fat tissue or the adipose tissue. And then also there are stem cells or regenerative proteins that are coming from blood, the bone marrow. Those are the hematopoietic stem cells. In peripheral blood, you can take blood and then centrifuge, and you can collect those platelet-rich plasma or PRP. PRP has become more and more known right now, more in the orthopedic community. I'm pretty sure some of you have heard about the PRP therapies that are being used, as I'm saying, through the orthopedic community for pain, joints, right? Also in the beauty side, it's becoming very it's like a buzzword, and people are using this kind of therapies. So they're taking it from the patient's own body and then implanting it in the same patient. Talking about adipose, there's many plastic surgeons that are grafting fat, or they're taking fat from the patient's own body and moving it to different areas. And the same goes to stem cells. So as I mentioned, the first 4 or 5 years of our adventure with the stem cells, we were only working with autologous derived stem cells from patients' own body and implanting it into themselves. And then we understood that there is a small problem with those stem cells. It's that every single patient brings their own stem cells that have gone through different years and the environmental aspects that the patient is involved, how many illnesses or disease the patients have. So those cells, when at the time of us collecting them, will have passed through so many different things that the consistency of results was not the same for all of the patients. For example, if we had 5 males that had a problem in the knee and all of them were 50 years old, if we would do the same exact procedure, those 5 patients would have different results. So we went back to the drawing board and said, okay, we gotta figure out a way, because we understand the stem cells are powerful and that they can do and can help with the quality of life of the patient. But how can we make sure that all of the patients that we sit down and inject can have the same response or close to the same response? And that's when we venture into the allogeneic, those donor-derived cells, right? And we honed it down into the placenta-based or the perinatal-derived tissue. That perinatal-derived tissue is the tissue that's between the mom and the baby. It's a tissue that is not from the mom and it's not from the baby. It's a human tissue, right? That usually gets discarded as medical waste. So as I'm going to go through this, all the tissue that we use is donated by consent mothers, delivering only a full-term healthy baby, and they're scheduled C-sections. So the collection is being done in the OR by physicians, but inside of a clinic, a hospital that is certified. So we avoid all ethical and moral concerns. This is one of the things that usually every time you say stem cells, people think about aborted fetuses or that you're killing babies. And I am so glad that I have the opportunity today to talk to you and to at least burst that myth that usually comes with the word stem cells, that you as an adult have stem cells and that there are stem cells in perinatal tissue or that tissue that's attached to the placenta and that can be donated at a full term through a C-section. So funny enough, there is so much information about this type of tissue that since 1910, there are reports of how physicians have used specifically the amniotic membrane And on Sunday, we had a women's panel for Women's Month, and there was an ophthalmologist there, and she is very familiar that field of medicine, who is working with eyes. They're very familiar with this kind of membranes, of donated membranes. After the surgery, they just patch the amniotic membrane, and the healing time progresses dramatically. So there's many case series that have been documented. As I said, it's over 100 years that that the medical community has used this type of therapies. So as I was saying, this type of donors, not only that they are healthy moms and babies, but we follow all FDA guidelines to make sure that those donors are eligible. So the mother signed an informed consent, but they also complete a physical medical checkup, complete a medical and social history, and then we do this screening on their blood to make sure that they are not carrying this, which are the most important infections that they would be carrying, right? So HIV, Hep B, Hep C, HIV NAT test, syphilis, West Nile virus, human T lymphotropic virus, cytomegalovirus, Zika virus, and now SARS-CoV-2 as well. On top of us following all FDA rules to qualify those donors, we do have an IRB protocol to qualify those donors. So there's an institution review board that's independent, that is looking at what are our qualifications to make sure that those donors are eligible to donate. So as I was mentioning, all of the 10 years that, or 13 years, over 15 years that we were working with stem cells, in transition from the patient's own body to the perinatal tissue-derived cells. We expanded cells, we cultivated cells, we worked with amniotic fluid, we worked with the amniotic membrane, we work with Wharton's jelly, we work with different types of cells and tissues in the perinatal tissue. And then at the end of the day, decided to just stay with an area where there were no more cells, because we understood that the cell-to-cell communication is done through these small particles called exosomes. And I'm going to dive a little bit deeper into this. But I am super proud to present to you that after all of these years of work, we have presented to FDA our investigational new drug. And this investigational new drug application that is presented to FDA, it's for them to consider this product as a drug, and we're going to try to prove that this drug will be for specific conditions. So this is the name of our drug, Sofin. Sofin is, as I mentioned, it does not contain any stem cells or cells, so it's a cellular drug. And it's manufactured for clinical use under CGMP compliant manufacturer conditions. To understand what is in this product, as I said, this comes from the perinatal tissue, specifically from the fluid, and it contains, one of the components is proteins. We have over 300 different cytokines, chemokines, and growth factors. Cytokines, chemokines, and growth factors are just proteins that do specific things, right? And we have a concentration of around 1.8 milligrams per ml. But what do they do? And I've used this simple chart to just present some of them, because I'm saying we have identified over 300 of those. But the specific thing that they are intent to do, they are basically pro-angiogenic. And if you are already involved in medicine and know a little bit of these terms, pro is that they are actively doing, right? Angiogenic or angiogenesis is the ability of creating blood vessels. So you know, when you have more blood flow or more blood vessels, you have more oxygen and more nutrients to that area. Usually when tissues, cells, and organs are not working properly, it's because they have a lack of vessels. So being pro-angiogenic is so important in terms of being able to deliver more oxygen and nutrients to that area. Also anti-inflammatory. I don't need to explain anti-inflammatory. Immune modulatory, meaning that these proteins can work directly with the immune system. Tissue repair and pro-metabolic. You need to have a correct metabolism for tissues to repair, right? So this is just a small sample of what those proteins can do. Then another part of the composition is hyaluronic acid. Hyaluronic acid is a key component for lubrication specifically, right? So if we are, one of our indications that we're working is in joints, osteoarthritis, specifically osteoarthritis of the knee. And for that, this component is extremely, extremely vital. And the one that we have dived in so deep, and the one that we are doing so much work, is in this part of the composition of the drug, the exosomes. Remember I told you cells to cells communicate through these small nanoparticles, which are called exosomes. So an average of one of our products, 1 ml of our products, contains between 200 to 400 billion exosomes, and the size is less than 100 nanometers. So the beauty about this is that when I went to med school, and even after I went to med school, when we were studying stem cells, we didn't know about the exosomes because there was no way to actually picture them. We learned, and some of the books, the medical books, still quote that these vesicles that are coming out of the cells are form of garbage that the cell is just excreting out. So we were not able to see it before, but now we have ways to see what's inside of these little vesicles, and we see that it's not garbage. It's actually information that's being transferred from one cell to another. So when we realized, when the entire scientific and medical community realized that this is what was going on, believe me, many companies have jumped into the space of the exosomes because we feel that this is going to be the future of regenerative medicine, of diagnostic devices, of diagnostic ways, because, and I'm going to explain about exosomes in a little bit. So the way that we, and this is one of our devices that we have in our laboratory to be able to quantify those exosomes. And tell me if you can see the video. I hope you can see the video.
Yes.
So this device did not exist back when I was studying medicine or before. We are able right now, through this Nanoside device, able to quantify those nanoparticles that are between 0.01 to 1 micron in diameter. So they're teeny, 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 tiny. So this instrument uses a laser beam that passes through a chamber, which the nanoparticles are suspended in distilled water. So the nanoparticles then scatter light in such a manner that they can be visualized by a 20x magnification microscope that's mounted to a high precision camera. So the light, here it is. So the light is hitting while those particles are moving, and the device is able to actually see how big they are and how fast they move, and therefore the size that they have. This is very specific. I'm going to just leave it here. You can go back anytime to review. I don't want to bore you with all the specifics of that device, but it's so fascinating how medicine advanced so quickly that we have to keep studying no matter what. Even though you think you finished pre-med, then you get into medicine, and you think that by graduating from an MD is done, then you go into residency, and then you go into your specialty, and then you go into subspecialty. But I'm here to tell you, even when you finish all of that, you still have to keep studying, because things just keep progressing so much. And depending on what you're going to specialize one day, believe me, going to the meets every year and meeting your colleagues, or just staying up to date in just reading papers every time, will keep making you a better professional. So just to explain more about what exosomes are, and I hope you're following me. Please hold your questions for the end. It'd be my pleasure to answer all of the questions. So exosomes, as I was saying, are extracellular vesicles, and they have an endosomal origin, means that they come from inside of the cell. They're released by many different cell types and participate in various physiological or pathological processes. Exosomes work as information messengers to recipient cells. So they are carrying a specific message. And it depends on the origin and information transfer, they can alter the fate of the recipient cell. So if the message that's inside of these exosomes can actually impact the cells that are receiving them, and those cells can change their behavior. For them to be considered exosomes, they have to be really teeny tiny, between 40 to 200 nanometers. So imagine, before we did not have a way to see them. Now we have a way to see them. And most importantly, now we have a way to see what's inside of them. And as I was saying, these vesicles are created inside of the cell, and they're loaded by these um, different messages that they're going to be carrying, either proteins like enzymes, or messenger RNA, or microRNA, and other proteins, as I'm saying. But this year, after this fabulous 2020 that we all have been impacted with, we understand that there's two vaccines that are they're based on messenger RNA. So it's so fascinating for me to be able to talk to a population that now understands something about messenger RNA. We understand that this is small pieces of RNA that are just carrying a specific message, right? So imagine these exosomes are carrying messenger RNA or microRNA that have that information of certain things, of what to do and what not to do. And that is how microRNA and messenger RNA relay their information. So they're moved from inside the cell to just the border to be excreted, and then they're released, and they can be absorbed by cells that are close to them or cells that are really far away from them. But once they get into the cell, the recipient cell or the target cell, they get in, they embed into the cell and then release their information, and that cell will read what's inside of those messengers. So something like a message in a bottle or a key in a lock, right? Just to transition what we have done for so many years in the laboratory and working on perfecting this kind of drug, we were able last year to present our drug for COVID patients, specifically for the lung damage. We have been working for many years in the preclinical data for COPD. COPD is a disease that is progressive, degenerative, and that affect the lungs. The lungs start to die little by little. So with all our preclinical data, we were able to present to FDA last March all of our rationale, and so we can carry studies to test our drug for specifically what I'm saying, COVID patients with the lung damage, with acute respiratory distress syndrome. And we're able to, after we got the approval from FDA, we were able also to treat emergency cases or compassionate use cases on different stages of COVID. So I am going to present a case study on one of these patients that received the drug. This is a 55-year-old male. He actually was a surgeon. His weight 79.5. The patient was hospitalized for 7 weeks due to mild to moderate acute respiratory distress syndrome due to COVID. During his hospitalization, he was admitted twice to ICU, but never intubated. So imagine how bad he was for first staying 7 weeks at the hospital and for him to be admitted twice to ICU, right? Nevertheless, he gets discharged, but at the time of discharge, the patient was still physically limited due to the severe deconditioning and having shortness of breath while performing limited activities like eating meals, showering, short distance walking. He even say that he couldn't shave anymore because just walking from his bed to his bathroom and trying to shave was extremely extenuating for him. So he really had a deep shortness of breath. His chest x-ray still revealed bilateral pneumonia at the day of treatment. So the way that we run the trials, we have to get several information from the patient, not before he gets treated, during all of the days of treatment, so we understand what's going on with the patient, right? So first, we needed to know that it was indeed a confirmed COVID-19 patient. He was able to sign an informed consent. The physician that was seeing him got all the information in demographics, medical history, did a great physical exam just to know exactly where the patient was. And we asked either a chest x-ray or a CT scan, but also these laboratory testings, not only the regular CBC and metabolic panel, but we wanted to understand, and this is probably more into what the research side is, we want to know how inflamed his body is, right? And we run these markers that are markers that let us know how inflamed the patient is. So those are IL-6, TNF alpha, D-dimer, and CRP. So interesting to follow along with the patient and what the patient had through these days that are the days that we were scheduled. Day 0, 4, 8, 12, 21, and 28. And he received the treatment of our product, Sofen, day 0, 4, and 8. Every day, he receives an assessment to know if he has any adverse events. The most important thing when you are trying a new drug into any patient is to always assess for adverse events. So none were seen in this case, but more specifically, these were the changes that the patient had. So on the day of the first treatment, the patient's oxygen saturation was really low at 96. Right now, if you all get an O2 saturator, you'll see your blood oxygen will be between 98 to 100. That is where it should be, right? And by day 8, prior to the third dose, the patient reported no more signs of fatigue or shortness of breath. Oxygen saturation improved to 97 to 98 after that first dose. And most importantly, in reviewing all of the chest x-rays, we see that there's no more evidence of that lung abnormality that was present before. And he was able to return back to work, and he was operating again after 1 more month of what we started treatment. This patient qualifies as those patients that are now known as the long haulers. So if COVID is something that we have never seen, humanity has not seen, the complications of COVID, we are just learning what that is. And my company is really wanting to understand and see if we can be a solution for those patients that are considered the COVID long haulers. So this is, as I mentioned, one of the patients that we studied and that has served us to with more evidence on the drug, be able to prepare an investigational new drug application specifically for long haulers that hopefully we receive the approval shortly. We're still working with FDA. FDA has been incredibly amazing working with us, so we can gear these trials and these protocols specifically to these patients. So I always like to leave a little quote. And after this year that has been so challenging, as just don't give up. Science will show up. And with you being the next generation of physicians, I want to say today is National Doctors Day. So for you future doctors, happy future National Doctors Day. And know that going through med school is not going to be easy. The days are not easy. The nights are not easy. The shifts are not easy. Dealing with so many emotions is not easy, but it's so worth it at the end of the day. Just hard work is all you have to keep doing and doing, because that's the only thing we have. But this year has shown us that 10 years of investigation of messenger RNA were able to be shift in a matter of days to decode that protein that the virus used to infect us, and that they were able to start trials so early on last year that a year later, soon we'll all be able to receive a safe vaccine, right? So science keeps evolving and medicine keeps evolving. So it's just a matter of trusting that it will happen and we'll all be able to get back to our new normal. Hopefully it is a normal where we can go travel again and visit our family again. But we're learning every day. So I am really open for questions. If you have questions, if I went too fast, hopefully you understood what I was trying to say. So please let me know.
I actually had two questions. First one is, when when the patient, from the case study that you decided to give the drug to, do they have to go through trials of other drugs first and then use yours as a last resort?
Yeah,
Or-
so for all COVID patients, and in this specific scenario that will not happen again in hopefully another 100 years, FDA was really open to, and most importantly, first, all patients had to try all of the approved drugs and the approved trials. So that is called standard of care. All patients were under standard of care. And as I mentioned, this patient went through the hospital for 7 weeks. So
Right.
he received all standard of care possible, but was discharged from the hospital. They had nothing else that they could do. And I don't know how it was in your state, but New York was very clear to move the patients from the hospital after they already completed the emergency cycle, and they were moved into more of the palliative medical scenarios, where they, I can come up with a word, but they were not being seen in the hospital anymore. They were moved into another medical facility for them to carry out.
Right.
And many are still left behind with not being back to normal. Those are the COVID long haulers.
Mhm. And then with that drug, are they on it for just 3 times and then that's it? Or
It's just an infusion, an IV infusion, and the protocol approved is only 3 times, day
Okay.
0, 4, and 8. And it's an infusion that lasts 30 minutes. So
Gotcha. Someone in the chat asked about how long ago did they find out about the importance of exosomes?
So it's not been too long ago, and that's why this field has evolved so in such a different way, where we were all focused on stem cells, and now some of us have diverted our focus from stem cells more into exosomes. But us, the company specifically, we went full dive 5 years ago.
If anyone has any questions, you guys can unmute yourselves, type in the chat. I'll read them off. If not, I have another question. When you were in, like, before like entering medical school, like how did you decide on doing like an MD, PhD program, and like what sort of balance between research and practice did you have?
So before I went to school, I think I was super influenced by my father because I was born and raised in a house that they always had the clinic really close. So we were always going to the clinic and knowing that he's treating patients. He dictated a lot of congresses. He still does. So I was always involved in medicine. So I knew that eventually, in I would say 10th grade, I decided I really wanted to become a doctor. And that's when I started pushing. But it came really natural to me because I was like an average student. But when it came to anatomy and biology, I was such a nerd. I loved it all. So I would study more and I would have really good grades. And then I honestly thought that I was going to become an OBGYN. I volunteered for 7 years during my med school through water delivery or more natural delivery. So I really thought that I was going to become an OBGYN until I rotated through the hospital and I was like, this is not for me. But that is something about medicine, sometimes you think you're really willing to do that. But you don't pass the exams or you did not match on that. But know that regardless of it, there's always a chance to set your timer back and say, okay, what can I do with the time that I have? I failed this exam. I didn't go into medicine straight away. I failed my exam to go into med school. So I still had some kind of grades that let me go into pre-med. And that was my university. So I had to do 6 more months in pre-med to then enter to medicine. But that is how life goes, and specifically in medicine, you're gonna get hit a bunch of times, but know that it's the stronger that you stand up, the stronger you keep pushing, and the further you will go. So one setback is not, it will not tell how you will end up in at the end, because it's just about just keep trying and trying and trying.
Mm-hmm. Definitely. Okay. In the chat, that's kind of the same thing I just asked. So what are your tips? Oh, we have another question. Go ahead.
Sorry, just to follow up with that. So did you have to take the MCAT, or like, I'm not really understanding how like you had to do 6 months extra before going into med school?
But that is because I went to school in Ecuador and the university is totally different than what you do here. So I did not qualify, like my grades did not qualify to get straight into med school. So we don't have college there. We just go from high school and you pick whatever you're going to study. And I did 8 years of med school. So I did not do like the first set that you do and then go to med school.
Oh, so you didn't take MCAT?
No, it's totally different there.
Okay, sounds good. Thank you.
You're welcome. But nevertheless, you're still studying the body, and the biology, anatomy, physiology is still human body. So wherever you do med school, and if you want to practice in the US and you have an MD from anywhere in the world, you still will come here and validate those with different tests, right? That will validate your degree from other countries and equal them to here so you can go to residency.
Thank you.
I know from Sunday panel, there is one physician that she went to school in the Caribbean. So there's a bunch of schools in the Caribbean as well. And that is what you do when you come here, you validate those. Mhm.
Someone in the chat asked, was Zofin effective for all the patients who were exposed to it, or were there cases where it showed negative results in some?
So far, all of our patients have shown the first and most important thing is safety, and all of the patients have shown safety. So no side effects have been seen, and we have used the drug in different scenarios of COVID. So our phase 1/2, which is a double-blinded placebo-controlled multi center trial, it's just for the moderate to severe. Then we have an expanded access for the mild to moderate, where all the patients are receiving the drug. And then on these emergency cases, we did also the ICU patients, which we actually got published 2 weeks ago in a peer-reviewed journal, all the findings of the first ICU patients that we treated. And then we also treated the long haulers or the long COVID patients. We treated 4 of those. So all of those have seen positive results. Some of the ICU patients were way far progressed. Some of them were in ECMO, and the drug did not do anything on those extremely severe cases. So we learned throughout this year that the drug can do in specific COVID. What can the drug do? And what we have seen is that the earliest that the patients get treated, the better it is for them, right? But nevertheless, we have to complete the trials, and that's the beauty about being a researcher, is that nothing is set in stone, and that as long as we can complete those trials and see what the results are and what the data is telling us, is where we will keep going forward.
Awesome. Someone asked, how did you deal with burnout going to school for 8 years straight?
Yes, and it's not only 8 years. 8 years only one until you get your MD, and then I did the PhD, and then the OMD, and then I'm still studying. And after you are done studying, then you are really practicing on real humans. So stories are real, and I think that is the most important thing to do, to learn how to navigate that burnout, because we are humans, and sometimes we are seen as doctors, first of all, that we always set ourselves for perfection. We always want to be the overachievers because there's human lives in the line. So learning from yourself, what can you do to balance that insane, because it's not only physical but it's emotional, that there's a lot of things that are going to come through your way. So what I did personally, but everybody has to find their way. For me, I found my therapy in working out. So I do make sure that I dedicate some hours to my fitness, whatever it was. Through med school, it was cycling. Now we have a Peloton, right? Before we did not have Pelotons. But for me, that was my avenue. Now that life has been even harder, I lift heavy weights and I do some yoga. But that is me, right? There's people that don't like to do that. There's people that are super creative and like to draw. But we've seen throughout burnout, what can help you the most is always making sure that you have a system of like a group of friends or family members that you can always reach out, right? Having a social network, making sure you sleep. I know that this is super not realistic through med school because I passed through it, but if you can try to schedule in the days that you cannot sleep, try to schedule other days where you can sleep. Sleep is really, really important for you to not get to burnout. And then any kind of either meditation or gratitude sessions, breathing sessions. And we're all so different that you have to learn to understand who you are and what takes you away from that and centers you back into right here, right now. And knowing that you are the most important thing, that is the key, because if you're not there, everything falls apart. So you have to dedicate time to your sanity and to your health.
Agreed. Someone else in the chat asking, when inventing the acellular drug Zofin, what kind of errors did you encounter, if any? And then how was the drug tested?
Millions of errors did we encounter. 15 years of trial and error. But that is the beauty of becoming a scientist, I guess. First, understanding what stem cells do and the potential of regeneration, then understanding the sources and why I thought it was so important to share with you the two big sources, either autologous or allogeneic. And then after us honing it down to perinatal tissue, then we tried different tissues to understand what would make the best reproducible drug, and honing it down to where we have it now. And then you do trials in vitro, so only in the Petri dish, right? And from that point, you transition into animal studies. And after all of that data is collected and you understand what you're doing, the concentrations, and how you can sort everything so you can mass produce, then you are allowed to transition into humans. So right now we have three ongoing trials. And as I mentioned, we're about to get the long hauler approval, hopefully soon, if FDA was okay with everything that we submitted today. But it is a constant, for this specific drug, which is a biologic, because most of the drugs that you're going to study and that you utilize in your counter is just this little bottle that you open the pill, right? And that there's one specific chemical thing in it. With biologic drugs, it's just a different amount of things that go into this drug. So trial and error is the biggest thing.
The last question I think we will ask is, what kind of benefits have you seen from having multiple degrees on top of your medical degree, especially working in the research sector?
Honestly, nothing that I study was ever applied into what I am doing now. So, but nevertheless, all of that has led me to be where I am, and I'm able to make decisions faster and quicker than I don't know. I mean, just the fact that I am not there's people that only study like microbiology or biology specific in cells, and that have their PhD on the cellular side, and those can lead a scientific department. But me being a physician before I was into the science, the specific science of cells, allows me to work so much more into the protocol and the trials with humans. And for me, my biggest focus is I want to transition from the bench to humans the faster I can, because I know that the end consumer is who's really needing the drug. So you know, life will give you so many different options, but at the end of the day, doing what you love is what you should be doing at the end of the day. And if I can throw one more thing, is even though you have a lot to study, if you can focus your attention into two different things. One is an MBA. You have to understand how to navigate business, because eventually, even if you work for the hospital, believe me, you would want to know how to manage your own business life, right? And or if you are going to have your private practice, you even more need to understand. We are taught only how to understand the anatomy, physiology of the human body, but nothing they teach us about business. And that is one thing that you really need to understand when you go out to the world. And the other is nutrition. They don't teach us nutrition, and nutrition can help so many lives. Doesn't matter which specialty you end up doing. If you start studying nutrition now, believe me, you'll help a lot more patients.
Yeah, my minor is actually in nutrition, so I totally agree. Even though I'm getting like only a small piece right now, but I 100% agree with that.
Yeah.
Okay, so I think we're gonna go ahead and end the session. It is 7 o'clock. So thank you so much for the incredible and insightful session, Dr. Mitrani. I really enjoyed how interactive and encouraging you were. If you would like to post any like social media handles or links to your business endeavors in the chat, please feel free to do so. To our Wayne State University students, please make sure you complete the Google survey. It should be posted in the chat soon. You should just have to summarize the session to obtain your shadowing hours. And thank you all. I hope you guys have a great night.